Hello, and thank you for taking the time to join us for the presentation titled Identifying New Strategies to Optimize Management and Treatment of COPD with Dr. David Mannino. My name is Kim Iman, and I'm with the ADAM Alliance. Today's presentation is brought to you through a collaboration of QIOs that strive to ignite powerful and sustainable change in healthcare quality in the states of Indiana, Kentucky, Tennessee, Mississippi, Alabama, Georgia, South Carolina, North Carolina, Virginia, Maryland, Washington, D.C., and New York. We welcome participants from these and all other states as well. At this time, I would like to introduce our speaker, Dr. David Mannino. Dr. Mannino is a medical expert focused on COPD at GlaxoSmithKline. He has a long history of research and engagement in respiratory health. He graduated from Jefferson Medical College and went on to complete his internship and residency at Lincoln View Hospital in Philadelphia. He completed his fellowship in pulmonary medicine at West Virginia University School of Medicine, National Institute of Occupational Safety and Health in Morgantown, West Virginia. He joined the Centers for Disease Control and Prevention Air Pollution Respiratory Health Branch in 1991 until his retirement from the U.S. Public Health Service in 2004. While at CDC, he helped to develop the National Asthma Program and led efforts on the surveillance report that described the U.S. burden of asthma 1998 and COPD 2002. After his retirement from CDC in 2004, Dr. Mannino joined the faculty at the University of Kentucky, where he was involved with both clinically in the College of Medicine and as a teacher, researcher, and administrator in the College of Public Health. He served as professor and chair in the Department of Preventative Medicine and Environmental Health from 2012 to 2017 with a joint appointment in the Department of Epidemiology. In 2004, Dr. Mannino helped to launch the COPD Foundation, where he served as a board member from 2004 through 2015, chairman of the Medical and Scientific Advisory Committee from 2010 through 2015, and chief scientific officer from 2015 to 2017. Dr. Mannino has over 300 publications and serves as associate editor and editorial board member for the following journals: American Journal of Respiratory and Critical Care Medicine, CHEST Thorax, European Respiratory Journal, Journal of COPD Foundation, International Journal of COPD, and the International Journal of Tuberculosis and Lung Disease. He was also co-author of the Surgeon General's report on tobacco in 2008 and 2014. Now, I would like to give the floor to Dr. Mannino.
Thank you, Kim, for that kind introduction. Today, I will be talking about COPD, which is my favorite topic to talk about, and that's particularly appropriate in this part of the country because the states that are covered in the introduction here are some of the states in the United States with some of the highest burden of COPD. So I'm going to start with my disclosures. As noted, as of August, I become a full-time employee of GSK as a respiratory expert. I also continue to do some work as an expert witness in cases typically related to COPD. And also, I need to state that the views represented in this talk are my own, not necessarily represent those of my employer, GlaxoSmithKline. And with that, I'd like to launch directly on to my objectives for the next 45 minutes or so. And I want to start initially by talking about some of the approaches that exist for both COPD screening, diagnosis, and patient monitoring. These are the guidelines that were published for both diagnosis and management of COPD although they were published in 2011, and these have not changed in recent years. And one of the somewhat controversial areas in this recommendation, although I think the data supports it, is noted here, and that is that spirometry should not be used to screen for airflow obstruction in individuals who do not have respiratory symptoms. And this is related to a push in recent years that spirometry should be done at least in patients over a certain age to identify COPD. And the data simply does not support this, although one of the problems is noted in the next recommendation is that many patients have symptoms, but they don't necessarily report these to their clinicians. So trying to balance between not doing spirometry in everybody, but finding people who actually have clinically important symptoms who don't report them has been a challenge. And this has actually led to an emerging tool that I, as part of a team of researchers, have developed, and it's called Capture. This was developed in conjunction with funding from the National Institutes of Health, and is currently in the process of being validated in a large primary care practice. And it consists of these very simple to answer 5 questions. The score is added up. If a person has a score of 5 or 6, they likely have COPD. If they have a score of 3 or 4, they probably have COPD, but the recommendation is that they're actually going to get a peak flow function measure, which can be done simply in primary care offices. If they have a score of 1 or 2, they are unlikely to have COPD. As I noted, this is being currently validated in a large study by NIH with also support from other funders. In terms of how COPD is both diagnosed and classified, there are some additional guidance out there coming from various organizations. Most widely known is that from the Global Initiative on Chronic Obstructive Lung Disease, known as GOLD, but also other organizations, including the COPD Foundation. If you go around the world, many countries have their own set of guidance. And this is the 2011 GOLD definition, where COPD had both presence of airflow limitation, pathologic changes, but also affects other parts of the body. And this is something that we've been paying more attention to in recent years. In 2011, GOLD introduced this concept of how one measures severity of disease by incorporating both a concept of risk, which is mainly driven by exacerbations, but also symptoms, which could be measured in several different ways. In 2017, GOLD modified their guidance a bit, as is noted here. And what had been happened previously is that lung function impairment, which is an important predictor of bad outcomes, was a part of the classification scheme. However, in 2017, this was modified such to recognize, I think, the reality that people sometimes, even with very mild airflow impairment, have a high burden of symptomatology that actually makes them more severe than one would think they would be otherwise. So this actually, I think, is a change that really reflected what happens in clinical practice. And the GOLD box is still down on the bottom, but now rather than lung function being an important measure of classifying disease severity with regards to therapy, one needs to have impaired lung function to get into the classification schema, but severity does not enter into that classification afterwards. And we still use both symptoms and exacerbations, because in the therapy of COPD, one is treating to both improve symptoms, but also to decrease risk of future exacerbations and death. And looking towards the future of how we will classify COPD, and we're also actually moving in this direction. This idea of having multiple different metrics, each of which requires their own type of intervention, such as lung function impairment, symptomatology, exacerbations, comorbidity, exercise capacity, and other factors. And this is an area that's been of great interest to me that we continue to develop. Because in fact, the COPD Foundation has used these metrics as their guide to therapy. For example, if you look at the GOLD guidance, oxygenation, patients that need additional oxygen is really not addressed specifically in those guidelines. And that's because oxygen is actually one of the few interventions that's actually been shown to improve or prolong life, and COPD is assessed on a completely different metric. So, and these other metrics may also require potentially different interventions. I'll now move on to the next concept, which looks at both the diagnosis and progression of COPD and how we consider pulmonary function in this. The spirometer was developed by Dr. John Hutchinson in the mid-1800s. And one of the realities that we deal with is that this is still the best measure we have of assessing what is happening in the lungs. So we really have not greatly advanced technology in more than 150 years. Although there is some hope for development of additional things in the future that hopefully will work their way down into primary care offices, that will be both affordable and easy to use. So stay tuned on that. If we now fast forward, and now this is a concept that is 60 years old, but this was Dr. Charles Fletcher put together a symposium that looked at how one classified chronic lower respiratory diseases. And the print on here is pretty small. But basically, he looked, and their group looked at patients with chronic bronchitis, asthma, irreversible obstructive lung disease, which is basically airflow limitation, and recognized that people had varying degrees of overlap between those. And this group went on to be called chronic obstructive pulmonary disease, or COPD, although I think there is an acknowledgement that all of these groups actually have important components of COPD, and in the 60 years since the publication of this symposium, we continue to sort of rethink this, although this was certainly incredibly instructive in helping us sort out lung disease. Another important concept in disease is demonstrated in this slide here. And this is the idea that by the time we were able to measure lung function impairment, which is, if you can see my arrow here, this idea of physiologic abnormality, the person has actually had disease present for many years, including their exposure and the onset of disease. So the question is there a way to start detecting disease earlier so interventions can occur? And that is also an area that is of great interest to those of us doing research in this space. This actually builds on the slide that I showed you previously from the Fletcher-Cita Symposium. And this is the idea of what actually represents COPD, that we have three overlapping circles of chronic bronchitis, emphysema, and asthma that were alluded to there, with the idea that people have varying degrees of overlap. As I had mentioned, traditionally, the viewpoint of what comprised COPD, if you go back 50 years ago, was this group here, patients with chronic bronchitis and or emphysema who had evidence of airflow obstruction. The initial guidance from Gold that is now almost 20 years old, basically said that anybody that had irreversible airflow obstruction had evidence of COPD. This has been expanded to actually consider, well, there's some patients that are sort of borderline who may have, obstruction that has some response to bronchodilator, but still would benefit from therapy. But this, of course, leaves out people that have chronic bronchitis or emphysema in the absence of obstruction. This can actually represent a type of early COPD. And then let's not forget our patients with asthma who actually have a specific type of obstructive lung disease. And then finally, a group that I've been very interested in, which are those patients that have restrictions spirometrically, but might actually have evidence of COPD if you dig deeper into their history. And when one thinks about natural history of disease, and this now actually sort of now incorporates, rather than the 1, 2, 3, 4, which was degrees of lung function impairment, this idea of severity in the new GOLD criteria, which is A, B, C, D, and which is represented here. And traditionally, the idea was that people move from health to incident disease. But I think now there's also recognition that people can move bidirectionally in terms of disease severity. And that is, in fact, why we treat patients with COPD, because you can take a patient from more symptomatic to less symptomatic, where we have treatment that actually decrease the risk of exacerbation, which is good. I mentioned a restricted group, and ultimately we're trying to not only add more life to the patient's years, but add more years to their life. And I think there's emerging evidence that we'll continue to see over the next couple of years that interventions can add longevity to the patients when done correctly. And this is another concept, and the idea that what happens very early in life, and sometimes even prenatally, has influences on what happens later in life, particularly with the development of COPD. So this is another area that we are interested in, that and besides interventions of patients who have active disease, to really focus on risk factors and to prevent the development of disease as best as we can. This is one of the favorite slides that I have, and this is the Ben Barrow's interpretation of the Fletcher and Peter curves. And the idea is, how do people develop disease? And the typical patient that shows up in my clinical practice has an FEV1 of somewhere between 50 and 60% predicted, and they show up in the 50s sitting here. And the question is, we don't know how they got there. And what Fletcher and Peter demonstrated is that there are multiple different paths that people get there. Some people never reach the maximal lung function, which is the green line. Some people have multiple events or exacerbations. Some people just rapidly lose lung function. And I put other lines in here with the idea that every patient has their own unique trajectory to the development of lung function impairment. And because we don't routinely measure lung function earlier in life, we don't necessarily know what that trajectory is. Another concept which is noted here is that the development of COPD is in large part related to aging. If you look at these metrics of both maximal work rate, which is how well the lungs function, and maximal breathing capacity, they all show a decline with age. So the question is, how can this potentially be modified? And I'll be addressing that later. Another important concept in COPD is something that actually has been somewhat, it was accepted, and this was the idea that people who lose lung function earlier in life, the sort of Man-S group here, continue to lose lung function. This was called the horse racing effect. With the horse race, you could have to be able to run for the roses. This would be the run for the Royalies, and the idea that the person whose lung function was lower at age 50 is more likely to have more rapid decline and die sooner. And this was widely accepted for many years, although what we have seen as we've basically gotten more data, but also developed more therapies, is that this may not necessarily be true. That in fact, as we've seen in data from from various studies, that the people whose lung function decline is the steepest are actually those who start out with the best lung function. And by the time a person gets to a rather severe impairment, such as those in the gold stage 4 group, that they actually have less steep decline in lung function. So if one although one would imagine that there was a period earlier in time where they actually had a steeper lung function decline. So I've described this as less of a horse race and more like a hockey match. Because in the shape of a hockey stick, there was probably a time, for this person in gold stage 4, where they will rapidly lose their lung function earlier in life. But this has now flattened out. And another important concept relates to how the definition of COPD and obstruction translates into the real world. Because in fact, if you look at this slide here, the important group are patients down the bottom here, 3, 2, and 2A, and these are the old gold classifications. These are patients that are considered to have clinically significant COPD, but if you look at patients, and these are patients that actually in the real world showed up in a COPD clinic, 14% of those fit into this restricted group, and a whole 30% fit into what is called now gold stage 0. So these are people that actually have a lot of symptomatology, relatively normal lung function, or people in this blue group here that were restricted, that clinicians consider as COPD and meritorious therapy. And these are groups that really have been ignored both in clinical trials, but now we're starting to pay more attention to as we sort of broaden our view. And I think both these groups, I think the yellow group up here may well represent a subgroup of patients with mild COPD or COPD that is early and symptomatic and merits intervention. And this then goes on to, other metrics beyond spirometry and the classification of COPD. And this looks at some advances in imaging, showing that this idea of heterogeneity or the lack of heterogeneity is something that we see in smokers who are, of course, at risk for developing COPD. And that's noted on the slide here. Another advance that we may see in the future is better imaging of airways. That can show airway thickening, as noted in the little pink area down below, that may indicate the development of bronchitic symptoms. Here's some additional imaging metrics. And this is important. It highlights that patients, when they have emphysema, tend to have a number of different types. They can have central lobular, which is CL. They can have panlobular. They can have paraseptal, which is in green. And so when one sees emphysema present, if one actually gets adequate imaging, you can see a number of different types of emphysema and not just one type. And emphysema now can be quantified radiographically, and this is another area where we may see potential changes in the future in terms of detecting early disease. This slide demonstrates that patients with, and this paper has now been published, but an impairment of diffusion capacity, which is in this case a diffusion capacity less than 80%, may be a marker for early COPD, as these patients are more likely to develop obstruction even if their lung function is normal at baseline. and that's demonstrated in this slide here, that a higher proportion of patients with impaired perfusion capacity developed obstruction in the follow-up, and you see that in this area of the slide down here, nearly 30%. So to summarize this section, although spirometry remains the best means of classifying patients, we're looking at technology that is more than a century and a half old. And I think in the future there will be emerging technologies that will hopefully provide us new options for both detecting disease early and better classification. I'm now going to move on to strategies to manage patients with COPD, both pharmacologically and non-pharmacologically. This highlights some of the key non-pharmacologic interventions. Of course, for patients with COPD who are still smoking, stopping smoking is the key intervention. Pulmonary rehabilitation is also critically important. The role of vaccinations is also critically important. On the news today, in fact, there was a report that patients who get their influenza vaccinations every year seem to have a benefit, not only for hospitalizations but also mortality. And that's in the general patient population. And although I have not seen data specific to COPD, one would think that COPD patients are at an increased risk for complications related to influenza that would also have a benefit. Oxygen therapy is also noted here, and I'll briefly be talking about surgical and non-surgical interventions at the end. If one looks at pharmacologic therapies, and this is a slide that is ever changing, because now we have an approved triple therapy for COPD that would be in this category here. But in that sense, we have short-acting agents that can be used to treat symptoms, longer-acting agents that are controlling agents, anti-inflammatories, both in combination and in isolation. And at the bottom we have PDE4 inhibitors, reformulants that's available in the United States. Some patients, although they don't have an approval in COPD, patients are maybe on some type of suppressive antibiotic therapy. Azithromycin is commonly used, and this has been shown to be beneficial in clinical trials. The role of statins in COPD is still being evaluated, although certainly statins have a role in patients with cardiovascular disease or risk factors for cardiovascular disease, and there's a large amount of overlap in our COPD population with cardiovascular disease. This was a traditional viewpoint of how patients with COPD were treated. So this goes back 15 years, where basically lung function was the main metric of treatment. That has now been modified with now the new tool box where one looks at both symptoms and risk to classify therapy, and we're basically patients that are the mildest, A box here, are treated symptomatically. Patients in the most severe box, which is D down here, tend to get maximal therapy, and those that are Bs or Cs, one has a lot of therapeutic options. This is what this approach looks like in the newest guidance. That again, in the A box down here, people are treated symptomatically, typically with asthmatic bronchodilators. People have both symptoms and exacerbations, which is the D box up here. They're treated with maximal therapy, and there's currently debate over what that therapy is. but it's typically at least dual therapy and triple therapy. And then for patients in these in the B and C box, one has a lot of options, either with or without an inhaled steroid as one of those options. COPD intubation guidance for COPD therapy is noted here. And this is somewhat more patient specific, and that really looks at each of these different measures of either of disease activity and has therapy targeted to each one of those. So again, more like a precision type therapy. And this has now been tweaked a bit in that the number one intervention or the initial phase in approaching the COPD patient, and this is certainly what I do in my clinical practice, is to look for the presence of asthmatic features in the COPD patient, and whether that's actually asthma COPD overlap or actually, what I now refer to this as asthmatic features in our COPD patient. And if a patient has those asthmatic features, I go to an inhaled steroid-containing therapy more rapidly. In the absence of that, so a patient that doesn't have asthmatic features to their disease, I go with this traditional, more traditional viewpoint, which closely follows actually what's in the GOLD guidance. So basically, if one looks at the presence of symptoms and or exacerbations, one goes either with short-acting agents or longer-acting agents as needed. As I alluded to earlier, what is the role of antibiotics in COPD? Certainly exacerbations are treated with antibiotics, but we're seeing that many patients are being treated with different antibiotics. In my practice, I use something like azithromycin 3 days a week. And this tends to be beneficial, and this is something that actually was borrowed from the cystic fibrosis world. Although certainly there are concerns about issues such as resistance and side effects, such as that related to hearing. But certainly, and this is a study that sort of pushed us in that direction, which was the macro study published in the New England Journal, demonstrating a decreased risk of exacerbations in the azithromycin arm. And similarly, when compared to placebo, one had a benefit for hospitalizations, and that was noted. So, suggesting a potential benefit here. The Cochrane review of this also favored antibiotics with somewhere between 30 and 40% reduction in exacerbations. Now, let's look at various different antibiotics, but all macrolides. The role of steroids in COPD. I've talked a little bit about this, and this relates to how important is inflammation in COPD. And I think this is important in some patients, but certainly not in all patients. And if one looks at, and this is data from TORCH, showing that patients on combination therapy had an improvement in health status relative to those on placebo, and with the evidence suggesting that steroids had a role in this. And this is the mortality data from TORCH. That wasn't quite statistically significant, but certainly pointed towards there being a benefit. Patients can be safely withdrawn from steroids, and this is data from the listening trial, although in this trial there was a decrease in lung function after steroid withdrawal. But there was no difference in subsequent exacerbations. So again, in certain patients, there can steroids can perhaps be safely withdrawn. And one of the risks related to steroids is pneumonia. And certainly in multiple trials, there's been demonstrated a pneumonia risk. So one of the metrics that I use and others use that if a patient has had recurrent pneumonias while on steroid-containing therapy, that is a rationale for either taking them off that steroid-containing therapy or changing from one steroid to another, as some steroids are actually more potent than others, so there may be rationale to change to a less potent steroid. And now I'm going to talk about surgical interventions. Lung volume reduction got a great deal of attention several years back, and demonstrated, for example, in certain subgroups of patients that this was harmful. So, for example, in the right-hand side, high-risk patients did much worse with surgery relative to medical therapy. However, in other subgroups, if you sort of excluded that group, patients with surgery, such as those with upper lobe predominant with low baseline exercise capacity, did better than those in just medical therapy. So again, in a specific subgroup, this is something I still recommend for some patients. But what is changing here is the idea that one could get the benefit of surgical lung volume reduction without the risk by endoscopic procedures. And this is an area of active investigation that where, at least in certain countries around the world, this has been approved. In the U.S., this is largely still investigational. But the idea here is that one could gain a benefit by using interventions to decrease emphysema of lung that's not functioning. Now, the ultimate goal is to move towards personalized therapies by balancing both risk and benefits in our COPD patients. Because as I mentioned, there are multiple risks involved, both with patients right for therapies and related to our various interventions. And we talked, for example, about pneumonia, osteoporosis, also related to steroids, and you get tremor and cardiovascular events related to beta agonists. But you hope to get benefits, as are noted here. So there's always that balance, and the idea is to get the right patient on the right therapy, and hopefully, and this is the model we would like to go at in the future, where we use both phenotypes, endotypes, and various exposures to target specific interventions. And there's some examples of how this might work. For example, patients with alkaline trypsin deficiency, we have a very specific intervention in that subgroup. And we're also now looking, for example, patients with eosinophilic type CO2 might benefit from specific therapies as compared to those with more pathogenic bacterial colonization. Might be the ones that, for example, benefit from bacterial suppression therapies. But the big debate, I think, relates to this here. Can we change overall organ decline? And this relates to COPD as being a disease of aging, and the concept that what might be a reality in the future are various anti-aging therapies, whether these are perhaps antioxidants or other specific interventions. And interesting enough, some of the people doing work in this demonstrate, for example, that apples or that the various things containing apples might have some strong anti-aging properties that could show multiple benefits. So the old adage of an apple didn't keep the doctor away may in fact be true. And this is the goal when one looks at aging, that these are the various trajectories, and all of us would like to be on trajectory A here, where one maintains a reasonable capacity till late in life. COPD and other chronic diseases are people on the trajectory C, and moving an intervention after disease is established might move them to one of these dotted lines, and that's really one of the goals that we have in not only specific therapy but more generic therapy that target aging in general. And that really relates to this concept here, is that, and that's polymorbidity. And the idea being here is that if a disease does not kill you, you will develop another disease. And the more diseases you have, the more likely you are to have complications of those. Patients with COPD tend to mirror the same polymorbidity map, but tend to have these diseases 10 to 15 years earlier. So again, sort of intervening here is important. And for the last component of my talk today, I'll be talking about how we can better educate our patients and caregivers to maximize therapy of COPD. Although action plans have been available in asthma for years, they haven't really caught on COPD for a number of different reasons. In part because COPD patients are older and have more chronic disease, and we really don't have it's not quite as simple as asthma. But certainly, I think the idea that some patients may benefit from this is something. This actually comes from the Lung Foundation of Australia, which I use some of my patients. We have a proliferation of different devices, and one of the challenges our patients have is that when they move from one device to another, they may not be using it correctly. And the idea of educating patients to use their devices is something that we need to do a better job at. Patients aren't necessarily adherent to their therapies. Some of these are medical factors, such as they can't use the inhalers. Some relate to cost and co-pays, and then some patients perhaps have either attitudes or cultural issues that address non-adherence, and all of these things need to be better addressed. So I'd like to conclude today by noting that our COPD approach and therapies continue to evolve, and ultimately we like to move towards more individualized therapies. I end all of my COPD talks with these two messages of hope: that COPD is preventable and treatable. And this is Kentucky's my personal awareness campaign for COPD, license plate on my car. And we get to drive around Lexington in the heart of the bluegrass here and see horse ones all the time. Thank you for your attention, and I appreciate your attendance today.
Please contact us if you have any questions about what you just heard or need technical assistance with your improvement initiatives. Visit us online and connect with us through social media. Thank you for taking the time to join us today. We appreciate all you do to improve quality and achieve better outcomes in health and healthcare, and at a lower cost that will come up as you exit the webinar. We value your feedback in developing future events.
Great. Thank you.